Hi everyone, my name is Casey Wiesen, and today we're going to be covering Chapter 9, the Gastrointestinal System. So the gastrointestinal system, or GI system, is responsible for consumption, digestion, and elimination of food. And the structures of the GI system include an alimentary canal, which consists of the oral cavity, pharynx, esophagus, stomach, small intestine, large intestine, and anus. And the accessory organs include the salivary glands, liver, gallbladder, bile ducts, and pancreas. Disorders within the GI tract can lead to nutritional deficits and metabolic imbalances and can range from mild to life-threatening. So the GI tract is divided into an upper and lower section, and there is also the hepatobiliary system, which includes the liver, gallbladder, and pancreas. There are also 4 layers to the walls of the GI tract, and see figure 9-3 for a great image of each of these layers. The peritoneum is the large serous membrane that lines the abdominal cavity. The outer parietal peritoneum layer covers the abdominal wall, as well as the top of the bladder and uterus. The inner visceral peritoneum layer encases the abdominal organs. The peritoneal cavity is the space between the 2 layers, and it contains serous fluid to decrease friction and facilitate movement. The mesentery is a double-layer peritoneum that is a serous membrane, and it is continuous with the serosa and contains blood vessels and nerves that supply the intestinal wall. It supports and connects the organs and intestines while allowing flexibility to accommodate peristalsis and varying content volumes. The upper GI tract includes the oral cavity, pharynx, esophagus, and stomach. Food enters the GI tract through the mouth, where chemical and mechanical digestion begin. Saliva contains enzymes which start the process of carbohydrate digestion and production of antibodies that can kill or neutralize bacteria, and also consists of water, mucus, and electrolytes. The olfactory nerve initiates saliva and gastric secretion and can be triggered by the smell, taste, feel, or thought of food. Saliva secretion is controlled by the autonomic nervous system, and parasympathetic cholinergic fiber stimulation inhibits salivation, and sympathetic adrenergic stimulation leads to salivation. The tongue pushes the bolus of food to the back of the throat where it is swallowed. There are various nerves that relay information from the swallowing center in the medulla and pons, which coordinates the movement of the food from the mouth through the pharynx and into the esophagus with the use of 4 nerves. The upper esophageal sphincter is present at the transition of the pharynx to the esophagus and is under voluntary control. The sphincter, along with the orchestrated movement of the bolus, prevents food from entering the nearby trachea and lungs. The esophagus has muscular rings to move food toward the stomach, and as the food nears the stomach, the normally closed lower esophageal sphincter, or the LES, relaxes to allow the food to enter the stomach. The LES also prevents stomach contents from refluxing into the esophagus. The stomach is an expandable food and liquid reservoir. When it is empty, the stomach wall shrinks, forming wrinkles called rugae. Prior to the arrival of food into the stomach, gastric acid secretion begins in preparation for the arrival of food. As the stomach fills, the rugae unfold, and the wall stretches to accommodate a volume up to 4 liters. Rugae present inside the gastric glands have different cells that secrete various substances, and these cells include parietal cells, mucus cells, chief cells, G cells, and D cells. Inside the stomach, hydrochloric acid and enzymes further chemically digest the food, and peristaltic churning further mechanically digests the food, and this new food mixture is called chyme. The highly acidic nature of chyme aids in the digestion and destroys in bacteria. The epithelial cells of the stomach's inner lining are densely packed together to prevent damage to the tissues through contact with the acidic stomach contents. Nutrients are not absorbed in the stomach. Instead, this is where food is prepared for absorption. However, the stomach does absorb some substances, such as alcohol, NSAIDs, and aspirin. Chyme leaves the stomach through the pyloric sphincter in small amounts, and as it passes through the pyloric sphincter into the duodenum, liver and pancreatic secretions are added to continue the digestion process. Much like the LES, the pyloric sphincter prevents reflux of bile from the small intestine into the stomach. The lower GI tract is comprised of the small intestine, large intestine, and anus. The small intestine is the longest of the GI tract, and this length allows for adequate nutrient absorption as the small intestine continues the digestion process. The intestines also receive approximately 10 liters of fluid a day, which includes dietary intake, saliva, and various GI juices. About 90% of the fluids are absorbed in the small intestine and 10% in the large intestine. The duodenum is an important site for mixing of food. Carbohydrate, protein, fat, bile, vitamins, and minerals are digested and absorbed in different locations of the small intestines. Muscular rings slowly move the food mixture through the small intestine using a peristaltic wave motion. The walls of the small intestine contain numerous circular folds covered with villi and microvilli, particularly in the jejunum and ileum. These projections increase the surface area available for absorption of nutrients. Each villus contains capillaries, nerves, and lymphatic vessels that play key roles in this absorption. The small intestine also contains cells that secrete fluid to neutralize pH and enzymes to facilitate digestion. Just like the stomach, the small intestine produces a large amount of protective mucus. Immune cells such as lymphocytes, plasma cells, and macrophages are located beneath the villi in the lymph nodules in the areas known as Peyer's patches. These cells act to monitor normal intestinal flora and as a defense against microorganisms. After making its long journey through the small intestine, the chyme ultimately reaches the large intestine, which usually takes about 3 to 5 hours. The large intestine consists of the cecum, colon, rectum, and anus, and it does not contain any villi. It does have a few enzyme-secreting cells, but has many goblet cells. The small intestine ends in a pouch called the cecum, and the appendix also attaches to the cecum. This small structure seemingly has no function, but it does have plenty of potential to cause harm. The ileocecal valve is a sphincter that controls flow of digested material from the ileum to the cecum and prevents substances from refluxing into the small intestine. The ileocecal valve is normally closed, and peristalsis from the ileum will stimulate intrinsic fibers and cause this valve to open. The colon makes up most of the large intestine and has 3 relatively straight sections, the ascending, transverse, and descending colon. The descending colon does become the sigmoid colon. The mixture entering the colon from the small intestine includes water, unabsorbed food molecules, indigestible food remnants, and electrolytes. One of the colon's main functions is to absorb the remaining 10% of fluids and electrolytes not absorbed in the small intestine. E. coli contributes to a large population of bacteria normally found in the GI tract, and they synthesize several key vitamins that are later absorbed by the large intestine. As the chyme moves through the colon, it changes into a fecal mass, and this fecal mass is moved through the colon by way of segmental movements. Peristaltic movements further promote colonic emptying. The movement of feces from the sigmoid colon to the rectum is controlled by the rectosigmoid sphincter, and the rectum serves as a reservoir to store the feces. The rectum expands when feces enter the area, stimulating the stretch receptors in the sigmoid colon and rectal wall. These receptors send an impulse through the enteric nervous system and spinal cord to elicit the defecation reflex. Defecation is consciously controlled and may require assistance from abdominal muscles. The Valsalva maneuver causes an increase in intrathoracic and intra-abdominal pressures and facilitates the passage of stool. Defecation control requires appropriate muscular and nervous function. The liver is an organ that is the hub of activity and performs as many as 500 different functions, including but not limited to metabolizing of carbs, proteins, and fats, detoxifying the blood of potential harmful chemicals, produce bile, remove damaged or old erythrocytes from blood to recycle iron and protein, and convert fatty acids to ketones. One of the critical functions that must be understood is how the liver metabolizes endogenous or hormones and exogenous, such as drugs, substances. The purpose of metabolism is to make a substance water-soluble in preparation for excretion in urine, bile, or stool. The metabolic processes are divided into phase 1 and phase 2, and drugs can be metabolized during one or both of these phases. See Figure 9-8 for specific details regarding each of these phases. The liver is protected by a tough membrane called the Gleason capsule. The liver also has a dual blood supply. The hepatic artery carries oxygenated blood from the general circulation to the liver to nourish the liver, and the portal vein carries partially deoxygenated blood from the stomach, pancreas, spleen, and gallbladder, as well as from the small and large intestines to the liver so that the liver can process nutrients and digestion byproducts. Oral drugs that are absorbed in the GI tract travel through the portal vein to the liver, which is known as the first pass effect, which may result in lower bioavailability of the drug and delay the onset of the drug. The liver is also one of the few organs that can regenerate, and this is primarily due to certain liver cells called hepatocytes that act as stem cells. The hepatocytes also produce bile and perform most of the liver's other activities. The bile flows from the liver through a duct system to either the gallbladder for storage or onto the duodenum. See Figure 9-9. The gallbladder is a small organ located on the undersurface of the liver that serves as a reservoir for bile. In addition to storing the bile, the gallbladder concentrates bile by removing water and electrolytes, leaving bile salts, bile pigments, and cholesterol. The presence of chyme in the small intestine triggers the gallbladder to contract, releasing bile into yet another duct system where it travels to the small intestine. If the gallbladder is surgically removed, the bile constantly flows directly from the liver to the small intestine. And the pancreas is nestled underneath the stomach and liver and has exocrine and endocrine functions. The exocrine functions include producing enzymes, electrolytes that are necessary for digestion. A duct system carries these substances to the duodenum to join the chyme. The endocrine functions include producing hormones to help regulate blood glucose. All right, so now we are going to move on to some of the disease processes related to the GI tract. Just a reminder that I am only discussing a few that I see fairly routinely in my practice, so please be sure to read your textbook as there are numerous conditions discussed. So first, vomiting. Vomiting is common, and it is the involuntary or voluntary forceful ejection of chyme from the stomach up through the esophagus and mouth. It may be protective or result from reverse peristalsis, such as a bowel obstruction. Increased intracranial pressure can also lead to vomiting. It can be associated with other symptoms such as severe pain that you might see with a migraine. Vomiting is coordinated by the medulla, and drugs, toxins, and chemicals can stimulate this vomiting center. Vomiting may be preceded by nausea or retching. It can lead to fluid, electrolyte, and pH imbalances, and aspiration of chyme into the lungs may also occur, leading to serious damage and inflammation. The appearance of vomit is important as it can indicate an underlying problem. For example, when blood is present in the vomitus, this can occur from several conditions that are caused by an upper GI bleed. Yellow or green colored vomitus usually indicates the presence of bile, which can be from a GI obstruction. Deep brown may indicate content from the lower intestine, possibly even fecal, and this frequently results from an intestinal obstruction. The force of which the vomit occurs is also important, as projectile vomiting is often associated with intestinal obstructions, delayed gastric emptying, increased intracranial pressure, poisoning, and overeating. Diagnostic procedures focus on identifying the cause along with fluid, electrolyte, and pH imbalances. Treatment focuses on the cessation of vomiting, maintaining hydration, restoring acid-base balance, and correcting electrolyte alterations. Gastroesophageal reflux disease, or GERD, is when chyme periodically backs up from the stomach into the esophagus. The presence of these gastric secretions irritates the esophageal mucosa. GERD is usually caused by abnormalities in the LES, which includes LES relaxation, decreased pressure, or GE disruption, such as that which occurs with a hiatal hernia or obesity. Reflux can also occur due to issues with acid clearance. Normally, the esophagus clears the acid using peristalsis and bicarbonate, and saliva neutralizes acid. Impairment of these protective mechanisms as a result of impaired esophageal peristalsis and problems with saliva bicarbonate neutralizing the acid can result in GERD. Gastric motility issues such as gastroparesis or pyloric stricture leads to a higher chance of reflux because chyme sitting in the stomach for prolonged periods can become more acidic, increasing the risk for chyme to reflux. Various factors can cause or contribute to LES abnormalities, including pressure changes that may originate from obesity, pregnancy, or other circumstances that cause increased intra-abdominal pressure. Smoking, alcohol consumption, certain foods, and some medications can also alter LES pressure. Some foods that can do this include chocolate, caffeine, carbonated beverages, citrus fruit, tomatoes, spicy or fatty foods, and peppermint. Some medications that may lead to this include nitrates, sedatives, beta blockers, calcium channel blockers, and anticholinergics. GERD can cause esophagitis, usually through the activation of the immune system. Esophagitis is typically diagnosed based on endoscopy findings because not all patients affected by GERD have esophageal injury. Reflux esophagitis is not so much a consequence of increased acid secretion, but rather occurs due to the amount of time the reflux is in contact with the esophageal mucosa. GERD varies in severity, and manifestations can include heartburn, regurgitation of food, and can lead to a sour taste. Other symptoms include nausea, dry cough, laryngitis, pharyngitis, and sensation of a lump in the throat. The pain associated with GERD sometimes mimics angina and may warrant steps to rule out cardiac disease. GERD can result in esophageal and non-esophageal complications, and risk for Barrett esophagus, which is considered a precursor to an adenocarcinoma of the esophagus, is higher in those with long-standing GERD and the presence of other criteria such as obesity or smoking. GERD is one of the top 3 reasons for a chronic cough in the absence of smoking and use of ACE inhibitors. GERD complications or other possible diagnoses such as GI malignancy should be suspected in individuals with symptoms and regurgitation such as GI bleeding, persistent vomiting, new onset pepsia after age 60, anorexia, unexplained weight loss, anemia, or first-degree relatives with GI cancer. Diagnosis is usually made through an H&P, and testing is not usually necessary. However, testing is indicated in the presence of other symptoms other than heartburn and regurgitation, or if there is concern for the presence of GERD complications. Diagnostic testing may include an EGD, esophageal pH monitoring, and esophagus manometry. Treatment includes, but not limited to, eating small frequent meals throughout the day and avoiding eating 2 to 3 hours before bed, losing weight, avoiding triggers, having surgery, and taking medications. See page 461 for a more comprehensive list of treatment for GERD. Gastritis refers to inflammation of the stomach's mucosal lining and can be acute or chronic. Acute gastritis is typically caused by infections or autoimmune conditions, and infections are often due to H. pylori, which is a gram-negative spiral bacterium transmitted through the fecal-oral route. Neutrophilic infiltration characterizes acute gastritis. Gastritis can be caused by internal and external irritants, including bile reflux, alcohol, cocaine, and medications. Severe stress due to major surgery, traumatic injury, burns, or severe infections can also cause acute gastritis because of tissue ischemia and decreased gastric motility resulting from the stress response. Acute gastritis can be mild, transient irritation, or it can result in severe ulceration with hemorrhage. It usually develops suddenly and is likely to be accompanied by nausea and epigastric pain. Chronic gastritis is associated with the presence of lymphocytes, plasma cells, and macrophages as opposed to acute gastritis. Chronic gastritis generally proceeds through phases. Initially, gastritis is superficial, then inflammation extends deeper in the mucosa and the gastric glands are affected. The final phase is gastric atrophy, during which glandular structures are lost. Chronic gastritis can also be classified as type A or type B based on the location of the injury. The clinical manifestations of gastritis reflect injury of the mucosal lining. These symptoms include indigestion, heartburn, epigastric pain, nausea, vomiting, anorexia, and malaise. The presence of blood in the vomit and melon can indicate ulceration and bleeding. Chronic gastritis develops gradually and can last for months to years, and it is likely to be accompanied by a dull epigastric pain and a sensation of fullness after minimal intake. Nausea and vomiting may also occur. Chronic gastritis increases the risk for peptic ulcers, gastric cancer, anemia, and hemorrhage. Diagnosis is usually made through an H&P, and an EGD can be performed to evaluate the mucosal lining and H. pylori testing. CBC and stool analysis. A CBC and stool analysis may also be done for occult blood. Acute gastritis is often self-limiting and resolves within a few days, and irritants should be identified and discontinued or avoided. Treatment varies based on the underlying cause. Chronic disease management is important to limit any complications associated with the inflammation, and pharmacologic management may be needed as well. Hepatitis is inflammation of the liver that can be caused by infections, alcohol, medications such as acetaminophen, anti-seizure agents, and antibiotics, and autoimmune diseases such as systemic lupus erythematosus, rheumatoid arthritis, and scleroderma. It can be acute or chronic, and the disease can be active or non-active. People with non-viral and viral hepatitis typically recover with no residual damage, but some people do develop liver failure, liver cancer, or cirrhosis. Viral hepatitis is contagious, whereas non-viral hepatitis is not. Both viral and non-viral hepatitis can result in hepatic cell destruction, necrosis, autolysis, hyperplasia, and scarring. Viral hepatitis accounts for approximately 50% of all causes of acute hepatitis in the U.S., and there are 5 types, each with their own characteristics. In the U.S., most viral hepatitis cases are caused by hepatitis A, B, and C. And Table 9-3 reviews the viral hepatitis, including symptoms and outcomes for each. Acute hepatitis proceeds through 4 distinct phases: an asymptomatic incubation phase and 3 symptomatic phases. Stage 1 is the prodromal or pre-icteric phase, and it starts around 2 weeks after exposure to the virus and includes symptoms such as abdominal pain, nausea, vomiting, malaise, anorexia, low-grade fever, and headache. The icteric phase begins around 1 to 2 weeks after the prodromal phase and lasts up to 6 weeks and includes symptoms of jaundice, pruritus, dark tea-colored urine or clay-colored stools, hepatomegaly, and right upper quadrant pain. The recovery phase is resolution of the jaundice approximately 6 to 8 weeks after exposure, and the enlarged liver can be present for as long as 3 months. Symptoms with hepatitis A tend to be abrupt and have a higher likelihood of fever and jaundice in comparison to hepatitis B or C. Nausea and vomiting are common to all types of viral hepatitis. Chronic hepatitis usually is a result of hepatitis B or C and is characterized by continued hepatic disease lasting longer than 6 months. Symptom severity and disease progression vary depending on the degree of liver damage. An individual can live with chronic hepatitis for years, but the person's health can quickly deteriorate with declining liver integrity. Chronic hepatitis can lead to cirrhosis and liver failure. Diagnosis is usually made through an H&P and confirmed with a serum hepatitis profile, which is used to evaluate for the presence of the antigen, and the antigen and antibody presence can help to distinguish between active infection, chronic carrier states, or recover or immunity due to vaccination. Treatment strategies concentrate on prevention, and vaccinations are the cornerstone of hepatitis prevention. There are vaccines available for hepatitis A and B. Once viral hepatitis is contracted, there is no method of destroying the virus. Most cases of hepatitis A and hepatitis E will resolve with no treatment and only supportive care is needed. The treatment of the others will depend on the degree of liver damage or other circumstances such as pregnancy. Hepatitis can be treated with interferon injections to improve the immune response and antiviral medications to decrease viral replication. Other treatments may be needed based on the underlying cause. Diarrhea refers to the change in bowel pattern characterized by an increased frequency, amount, and water content of the stool. Diarrhea can be acute or chronic and may be caused by many conditions. Acute diarrhea is most often caused by viruses such as norovirus, rotavirus, and adenovirus. Bacterial infections may be implicated in more severe cases. Gastroenteritis is an intestinal disease manifested by acute onset of diarrhea, nausea, and vomiting due to infection. Diarrhea can also be triggered by certain medications. Depending on the cause, acute diarrhea is often self-limiting, and causes of chronic diarrhea are usually non-infectious and include inflammatory bowel diseases, irritable bowel syndrome, malabsorption syndromes, endocrine disorders, chemotherapy, and radiation. Clinical manifestations of diarrhea vary on the underlying cause. When the condition originates in the small intestine, stools are large, loose, and provoked by eating. Diarrhea originating in the small intestine is usually accompanied by pain within the right lower quadrant along with bloating and gas. When diarrhea originates in the large intestine, stools are small and frequently accompanied by pain and cramping in the left lower quadrant along with painful defecation. Fever and blood or mucoid type stool are more common in the large intestinal diarrhea than with small intestinal diarrhea. The blood in stool may be frank blood, occult blood, or melena, and bowel sounds may be hyperactive. Fluid and electrolyte and pH imbalances can develop regardless of whether the diarrhea is acute or chronic. Diagnosis is focused on the underlying cause and any complications. This may include an H&P, and sometimes stool analysis is needed. A CBC, blood chemistry, and other testing may also be needed. A CT can be performed in those with complications. Treatment varies based on the underlying etiology. Maintaining hydration status and correcting electrolyte and pH imbalances is crucial in managing acute or chronic diarrhea. Acute diarrhea with infectious origins usually improves with short-term fasting. Generally, food consumption slows GI motility, allowing bacterial and viral toxins to increase. As toxin levels rise, diarrhea can become more severe. Antidiarrheal agents may be withheld to avoid the accumulation of the toxin, and sometimes antibiotics may be necessary depending on the infectious agent. Probiotics can maintain normal flora and reduce the duration of diarrhea. When oral intake is recommended, a clear liquid diet is usually ordered until the diarrhea subsides, and then the diet is advanced as tolerated. Dairy products and fatty foods are best avoided as both may aggravate the diarrhea. Dietary fiber can be used to manage chronic diarrhea. Constipation refers to the change in bowel pattern habits characterized by infrequent passage of stool. Bowel patterns may vary from person to person, so it is important to determine the decrease in frequency in reference to the individual's bowel habits. With constipation, the stool remains in the large intestine longer than usual, and the longer the stool remains, the more water is removed from the stool. This leads to the stool becoming hard and difficult to pass. Constipation is often caused by a low-fiber diet, inadequate physical activity, insufficient fluid intake, delaying the urge to defecate, or laxative abuse. Stress and travel can also contribute to constipation or other changes in bowel habits. Diseases of the bowel such as IBS, pregnancy, and medications such as narcotics and iron supplements can lead to constipation. Other causes include mental health problems and colon cancer. Constipation is also common in children who are toilet training, especially if they are not ready for training or fear of toileting. Constipation may involve pain during the passage of a bowel movement, inability to pass stool after straining or pushing for more than 10 minutes, or no bowel movement for more than 3 days. Bowel sounds may be hypoactive. The passage of large white stools may tear the mucosal membrane of the anus, especially in children, and this tearing can lead to bleeding and cause an anal fissure to develop. Chronic constipation can also lead to pH disturbances, hemorrhoids, diverticulitis, impaction, intestinal obstruction, and fistulas. Diagnosis is focused on identifying the underlying cause. This includes completing an H&P, abdominal X-ray, upper GI series, barium swallow, colonoscopy, and proctosigmoidoscopy. Treatment is focused on reestablishing the individual's usual bowel pattern and preventing future constipation episodes. These strategies may include, but not limited to, increasing dietary fiber and hydration, increasing physical activity, taking stool softeners, and limiting the use of laxatives and enemas. In colorectal cancer, most often develops from an adenomatous polyp. The large bowel is the most common site, with a small proportion affecting the rectum. According to the World Health Organization, colorectal cancer is the third most common cancer and the second most fatal worldwide, and the American Cancer Society reports colorectal surgery as the third most common and most fatal cancer in men and women in the U.S. Dietary factors that have been associated with colorectal cancer include excessive intake of fat, calories, red meat, processed meat, and alcohol, as well as deficient intake of fiber. Other risk factors include genetics, family history, advancing age, obesity, tobacco use, physical inactivity, irritable bowel disease, and history of abdominal irradiation. Colon cancer or colorectal cancer remains asymptomatic until it is well advanced, and manifestations are dependent on the location of the tumor. When present, clinical manifestations may include lower abdominal pain and tenderness, blood in stool, changes in bowel habits, narrow stools, unexplained anemia, unintentional weight loss. Routine screening can dramatically improve prognosis, and screenings tests include stool-based tests such as Cologuard, flexible sigmoidoscopy, CT colonography, or colonoscopy. Cancer stage 1 through 3 require extensive surgery. Chemotherapy and radiation use vary depending on the cancer stage. The patient may also require a temporary or permanent colostomy because of a colon resection. Because colorectal cancer often recurs, lifestyle changes and follow-up screenings are crucial to long-term survival.